University of Pennsylvania in Indiana County, Pennsylvania in the US of A. Our second paper presentation we'd like to do for the World Nursing Conference was done by myself and my colleague, Dr. Sandeep Ziddick. I'm Dr. EUS, and it was on an innovative approach to complex client simulation in community health that we did with our senior level community health students in the lab, in the SIMS lab that we have here on campus. By way of introduction, when we were looking at how we wanted to do something innovative with our students in the classroom, there seems to be a lot in the literature on simulation improving the students' critical thinking skills and confidence level using Simulation Lab, though a level of complexity can be achieved with high fidelity use of simulation. For individual clients at the bedside, like where you're using it to do mock codes and things like that with students at in a hospital setting, there's a lot less that's available for community health setting and at home health or other community settings. Schools here in the US can purchase prefabricated client simulations that are med-surg based and not necessarily community health focused. What we have here at our school is something called Laerdal, which I'm sure many of you heard of. It is a worldwide company. So a lot of the stuff that we get, we have some prefab things on med-surg from Laerdal company. So we were using these in our simulations, and we found that we might be able to expand on it and have our students do a simulation with greater complexity, like what you see in a community health setting, and change the setting to be more of a home health setting versus a hospital setting. Also, what's available is National League of Nursing has a lot of, not a lot, but they do have some community health focused simulations on home health that go from hospital to home to back to hospital. So, but the complexity often is not there, and a lot of what we're doing in our course objectives, we would have to add to the simulations in order to make them relevant to our to the learning needs of the students here. So we wanted to do a simulation that would improve critical thinking for our students, try to do a learning versus a teaching paradigm, because it seems to be we provide them with all the pieces to do the simulation, and then they do the simulation. To have them more involved in the actual production of the simulation, in that way they could do the learning objectives themselves and bring in a lot of what they've done in community health home visits, application piece to the clinic, to the simulation setting to make it more relevant for the students.
The next part, the literature review, if you want the detailed version, you can find that in our paper, but I'm just going to hit the high points for the literature review for this project. The thing that we found with simulation and the literature, the research that's out there on it, nursing students are experiencing increases in critical thinking abilities. They're more satisfied with the care that they're giving. Their self-confidence increases before they go into a clinical setting. That's some of the, along with assessment and technical skills, those are things that you see in the literature. The other thing that we're finding is with home health, students need a more active approach, and we chose constructivist theory for this part of the project just because we wanted students to be more active in their learning, more involved with their learning, increasing their own growth and conceptual growth, which is a hard thing to do. Remember, we have senior nursing students. This is senior level community health project, a senior level simulation. So what you see is a paradigm shift. We all know the traditional role, the traditional teaching model where the desks are in a row, the teacher has the loudest voice, they're in front of the class, and the teacher knows the content. They're the expert in the room. When we chose constructivist as a model, we're looking at students taking a more active role in their learning, students directing the activities, the teacher circulates and the teacher's the facilitator, but the students are really actively engaged in their learning for this sim project that we did. The thing is, if you think about it, how do we help students become better learners? The theory, the research that's out there that we found in the literature review supported the constructivist model. The constructivist model will help us in community health, help the students apply existing knowledge, help them apply their prior clinical experiences, and in the other hand, it helps with hypothesis testing.
So how we chose to apply the model that my colleague, Dr. Zinnick, just explained. We used the existing materials that we had from Laerdal, and we tried to come up with a guide sheet that the students would use to create their own simulation, as well as actually do the simulation. They were to use a student was to be role play the client. We did this with students that had already been out in home health towards the end of their home health experience, where they've actually been in homes and doing the actual care. So they weren't, so it wasn't all new information, and they creatively used a lot of that information in the simulation because they were applying what they got from practice. So this is just, the slide just kind of shows you just the front end of what the simulation guide that we gave the students looked like. In addition to the guide that the students were given, that this faculty worked out, whereby they came up with their own learning objectives, they came up with a situation that they had, a client situation. They also did the doctor's orders for the client, and key events checklists for the actual simulation that were used in the briefing and debriefing that the students used when this actual simulation was going on. And the faculty provided feedback to the students. They had 2 weeks to give us the information, and we got a chance to give them feedback on it, and they could change it based on, we wanted to make sure they were coming up with heading in the right direction regarding the simulation they were going to do. We provided them, as part of the guide, we had 3 clients, and we had 7 to, what did we say, Cindy? 7 to 8 students in a group, 3 groups of 7.
I think we had 6 or 7.
6 or 7. Groups of 6 or 7 students in each of the groups, and we tried to have them do a complex client, create a complex client situation. Client 1 was a cardiovascular client that had also had Alzheimer's. Client 2 was a client with type 2 who also had diabetes and a GI history, and client 3 was a renal client who had hypothyroidism. We included medications. These medications happened to be objectives in our course that we wanted to make sure the students knew, and they had to have clients that were on these that they were actually caring for in the home setting. And we also wanted to kind of throw a wrench in there and really bump up the bar by having them include a concern. Much of what they were seeing already as they were doing the home visits, a safety concern in the home. Client 2 was to do somebody with a health literacy or compliance concern in the home. Client 3 was to have a cultural concern, or have a client of a different culture that they had to care for, to kind of bump up the bar and make it a very complex, as well as meeting the objectives of the course type of simulation. The student's role, they were to move from passive to more active learner by participating in coming up with the simulation. They were to create their own learning objectives. They were to create complex client based on the guide that we gave them. And this idea was to help them improve their critical thought process throughout the whole process, not just actually caring for the client, but the other end, using the constructivist theory to kind of broaden their horizons, as it were, educationally.
The next part of this presentation discusses how we implemented student-driven scenarios and best practices that we found for the scenarios. There's some helpful hints in here that takeaway things you can use in your own settings. All the students came prepared. Dr. West mentioned before they had to turn in their projects, had to meet our approval. All students came prepared. They also were prepared in terms of their roles. Who was going to be the RN, who was going to be an assistive personnel, were their family members, who was going to be the client, just different parts of the scenario. So the students had their roles. I have the some of the list of the roles for the simulation. The students had their roles, they came prepared, and then presented to the rest of the group, which would have been probably 14 students and 2 faculty. Some Some things that we use during our implementation, you'll see on this next slide, the first thing is a debriefing model. Debriefing is a big part of simulation. There's been a lot of research out there on debriefing. This wasn't our project, but what we found attending the University of Pittsburgh, the WISER elite conferences, Dr. West and I both attended. We came away with a debriefing model that we used in our simulations. It's on this PowerPoint slide. Gather, analyze, summarize. First gather information, analyze the information, and then summarize it. You can read the slide at your convenience, but this model from the University of Pittsburgh works very well. The next thing that we used was we had one student in the group. This isn't faculty driven. We had one student listening, watching the scenario, and then listening to the interactions afterwards. One student drew lines between all these squares and marked which student spoke with which faculty member or student in the front of the room. What you see on this slide, when we have students come from simulation, the sim team stands in the front of the classroom or sits in the front of the classroom, and this is the way our classroom is set up with 2 tables, and then you can sit in a circle around the room, which in itself the setup is better for active participation. But we have the stars, we call them, our simulation team, the people that ran the sim and participated in it, in the front of the room, and then the rest of the nursing students and Dr. West and I are in there. One of the students, one of those little squares marked X, or S, one of the squares marked S, sat there with this grid and drew lines between who was speaking to whom. You can look at that at the end of your simulation experience and the end of the debriefing and see if there is someone that's hogging the show. Are they directing too much attention to the instructors when really the interaction should be between students and the sim team. This was a way for us to determine, is this really working? And we found, yes, it really works. As faculty, we knew to redirect them to the sim team if they were addressing us, because it wasn't us, it was the students that created the simulation, and the students were the experts. Those were the 3 tips that we have for implementation. They have to be prepared, use a good debriefing model, and pay attention to your communication strategies in your group.
Regarding evaluation of this project, we did a student survey. It was a 5-point Likert scale and had 8 questions on it. The things that we pulled out from the data that we got from the survey, so by the way, it was voluntary for the students to complete it, and all 20 of the students chose to complete it on their with no problem. The simulation strongly agrees. The things that leaked out were the scenarios were realistic. In many instances, students brought things to the simulations we didn't ask them for in the guide. For instance, they've done venipuncture, so they added that to their simulation. They had actual situations with non-compliant diabetics in the community that they brought in and had the student that was role-playing actually do the communication patterns that they had seen, and caused a great deal of great discussion in the post, in the debrief, for students to discuss, well, what would you do with this, or how would you meet the client's need that was real world, which they found extremely useful. Also, the importance of delivering safe care during the simulation. Home care visit was stressed. That they strongly agreed with that. They saw the value to sim in relation to real world, which was huge in my mind. Also, which were other things that came out as agree or strongly agree. The purpose was clear of the sim, was well organized. They liked the guide sheets and the feedback they got, and so they weren't out there just creating stuff on the willy-nilly. They felt they were given enough information to do it well. It was well organized, appropriate learning activity they felt for them at senior level, and they liked the idea of being, as my colleague said, the experts and speaking to each other about what they were doing. Pre and post briefings also helped them understand and participate. There was nothing on that survey that was below an agree. Everybody seemed to think it was a valuable learning experience and understood the value of critical thought that went into actually taking the lead role on doing the simulation as well as running the simulation. So limitations, the idea, role play versus high fidelity simulation. This could be a limitation or a strength, I'm not sure. but we would have liked to have run the high fidelity simulator. It's just, we didn't have a lot of turnaround time for what was scripted by the students that they ended up role playing to be put into the computerized version to be used with high fidelity. Students like the role play, they like that acting thing better actually than the high fidelity simulations. However, the limitation was they couldn't change the vital signs. They were taking vital signs on each other, or they had to use a venipuncture arm that was kind of broke the, I don't know what you call it. We were using an arm and they weren't using the actual patient's arm, so it wasn't, they kind of broke from the real world or the reality of the situation by having to use equipment in addition to the client's actual arm. Whereas if we used the simulator, we could have had things programmed and had things change, and they would have been able to do that. Wound change they could have done with an actual wound instead of, there wasn't an, obviously the student's leg did not have a wound. So I mean, there were some drawbacks with that. So they had to pretend for some of this, which that would be a limitation. Skills application, those things like venipuncture, wound care, and vital signs could have been improved by the use of the high fidelity simulator versus role play. And also time constraints to actually get the role play, what was done into the high fidelity simulator. The good thing about this is now that it ran, and maybe if it was taped in the lab by our sim specialist, we could possibly, now that it's run once, actually do a scripted version for the simulator to be used by the high fidelity simulator. But I hesitate to say to do that because the students really like the actual using each other and bringing in application stuff. So there wasn't a whole lot of limitations in my mind.
In conclusion, one of the things we found was the students that created simulations thought it would be a better experience if the other group of clinical students ran the simulation. In other words, those who wrote and scripted would like to pass it on to their peers to implement, and then they would get one scripted by someone else for them to run. So we had two different nursing student groups. We would let the students script it and give it to a different group to run in the future based on their recommendations. The other thing to remember, the process of simulation, we were looking at constructivist theory and a way to actively engage students in the learning process, which we found very helpful with this type of simulation activity. What we found, most of the sims that you see out there, and ours also, meet the course objectives. You start with that, it meets the course objectives. What we didn't have was a cost-effective version of home health sims. It was very cost-effective for students to script sims and then implement them. And the final thing was increased student creativity in active learning. We feel this was a best practice, a best learning environment practice. Future research, we do need to look at more than just student satisfaction. The questionnaires we tend to use right now for simulation activities focus on students learning are they satisfied, is it realistic, what would they do differently. The thing that we don't really look at the moment is how are we affecting critical thinking and how are we affecting student comfort, confidence levels, that sort of thing. So we do need more research in terms of student scripted simulation and the impact on critical thinking and self-confidence. You will find all of our references listed at the end of the PowerPoints. You also have them in the printed white papers that you received. Thank you.